Greetings to the judges. My name is Juan Vargas. I'm a third-year internal medicine resident at Verde Valley Medical Center in Concord, Arizona, and will be presenting a case of hyperaldosteronism presenting as a myocardial infarction. Starts with a 41-year-old female with a medical history of resistant hypertension, morbid obesity, and chronic hypokalemia, who came to our facility with complaints of severe sudden onset of upper chest pressure and lower neck pressure that awoke her from sleep associated with shortness of breath. Worth noting, her blood pressure regimen at home included hydrochlorothiazide 12.5, metoprolol succinate 50, and amlodipine 10 milligrams, along with chronic potassium supplementation. Vitals upon arrival were notable for a blood pressure of 255 over 150 millimeters of mercury. She was noted to be obese and in moderate discomfort, in normal sinus rhythm, slightly tachypnic, and with 1+ spinning edema in bilateral lower extremities. Her lungs were documented to be clear to auscultation. Initial workup with an EKG revealed a Q wave in lead 3 and 1 millimeter ST segment elevations in leads 2, 3, and AVF, as seen in the EKG in our poster. Chemical workup revealed a troponin T of 0.27 nanograms per deciliter with a cutoff at our lab of 0.09, BNP Pro 56 picograms per milliliter, and a critical potassium at 2.3. Given these findings, the patient was started on systemic anticoagulation with unfractionated heparin. She received full-dose aspirin, torvastatin 40 milligrams, along with nitroglycerin ointment, with resolution of her chest pain, resolution of EKG changes, and improvement in her blood pressure. Cardiology consultation was placed, and she was taken to the cardiac catheterization lab. At the cath lab, she underwent a diagnostic procedure, and she was found to have normal coronaries. There was no coronary obstruction at the time, for which she was then transferred to the telemetry medical floors for further medical management. Her blood pressure remained persistently elevated, for which she was started on the appropriate medications, and a transthoracic echocardiogram done very shortly after her arrival to telemetry revealed that she had an ejection fraction of 65 to 70%, with normal left ventricular function, which was discordant with the left heart catheterization that revealed a ventriculogram with about an EF of 45%. Her transthoracic echo also revealed severe left ventricular hypertrophy, as noted in the picture in our poster with the 4-chamber view. She was noted to remain critically hypokalemic during her stay, with very elevated blood pressures requiring escalation of her blood pressure meds. And further endocrinologic workup was pursued, revealing an aldosterone level significantly elevated at 61 and renin levels at 1, which is suppressed. She was then started on spironolactone 100 milligrams daily with appropriate response to her blood pressure and potassium levels, as well as with supplementation. But this triggered further endocrinologic workup with imaging. CT abdomen was done that revealed a 0.8 centimeter nodule in the lateral limb of the right adrenal gland. So given these findings, it was very highly suspicious that the patient was experiencing primary aldosteronism. And at our facility, we were unable to perform adrenal vein sampling for further workup, but given appropriate response to spironolactone along with carvedilol and lisinopril, and normalization of her potassium, she was safely discharged with instructions to follow up with her primary care provider for further workup and evaluation. As we can see, chronically elevated levels of aldosterone, well documented in the literature, that there is a well-known relationship with cardiovascular morbidity and mortality. Studies have shown that patients with ST elevation myocardial infarction were found to have a proportional increase in the rates of in-hospital death, cardiovascular death, heart failure, and ventricular fibrillation, along with cardiac arrest. And patients with primary aldosteronism have also been found, and it's well documented in the literature, to have a greater left ventricular mass and decreased LV function. There are several proposed mechanisms for this, or for these negative findings of aldosterone in cardiovascular outcomes. And one of them is the lowering of nitric oxide levels, increased inflammation, smooth muscle proliferation and fibrosis, promoting calcification, and of course myocardial remodeling. Another mechanism is the presence of reactive oxygen species and coronary vasoconstriction that lead to left ventricular dysfunction, myocardial fibrosis, and ultimately resulting in heart failure. And as we saw here with our patient, it depicted exactly those mechanisms, and it showed the pathophysiologic role of aldosterone in changes in the left ventricle along with dysfunction in the absence of coronary disease in this young patient. It is also important to highlight that in spite of some risk factors such as hypertension, morbid obesity, and hypertriglyceridemia, there was no evidence of obstructive coronary artery disease in her left heart catheterization. And in conclusion, we know that hyperaldosteronism has detrimental effects in the cardiovascular system. And in this case, we were able to see a type 2 myocardial infarction that was associated with left ventricular hypertrophy and dysfunction in a young female with resistant hypertension. Despite hyperaldosteronism's association with negative cardiovascular outcomes, patients with resistant hypertension don't generally have aldosterone levels measured, which is something very important to do in the outpatient setting to prevent their presentation to the inpatient setting with acute conditions such as this patient. Aldosterone testing in these selected patients would lead to the appropriate management with mineralocorticoid receptor antagonists and maybe even more invasive therapy with removal of a possible nodule, as in this case, hence reducing cardiovascular morbidity and mortality in this population. Thank you.